Good evening, everyone. I extended a warm welcome to all those gathered here today, including our respected senior teachers and doctors. I would like to express our gratitude to our PG student for presenting the case. Also, we feel privileged to have such senior teachers who give a lots of insight of the topic. There is one shloka in the Sanskrita, Acharyam Padmadate Padam, Acharyam Padmadate Padam, Shishya Swamedhaya, Shishya Swamedhaya, Shishyasya Padmadate Padmam, Shishyasya Padmadate Padmam, Chaivacharyah Swayam, Chaivacharyah Swayam. जसं गुरुवर्य आपल्या ज्ञानाने शिष्यांना उच्च स्थान प्राप्त करून देतो, तसं शिष्य आपल्या ज्ञानाने आणि मेहनतीने पण गुरूंनाही उच्च स्थान प्राप्त करत असतो. And we are very lucky to have such platform and a great teachers to achieve this. So let us start our second clinical meeting on the near miss obstetric cases and panel discussion on obstetric hemorrhage. As we know, obstetric hemorrhage is a nightmare condition to each and everyone. There are 4 R's in the aims of obstetric hemorrhage patient's safety profile. These are readiness, recognition and prevention, response and reporting. To know more much inside the topic, we have conducted such CME. So let us start our first clinical case presentation. The first case presented by Dr. Rushali Trammale on near miss obstetric cases. The topic is, the case is uterine scar rupture in the termination of IUFD in the 17 weeks of gestation, a rare thing to encounter. Dr. Rushali Trammale is a OBGY GR3 resident of Solapur Civil Hospital, participate in AMOGS for paper and poster presentation. Paper topic is ERAS protocol and poster topic. Participated in SOGS clinical meeting with the topic of stepwise approach in the management of placenta accreta spectrum. So I invite Dr. Rushali to proceed further.
Good evening to one and all, and thank you so much, ma'am, for the sweet introduction. Before starting with my presentation, I would like to express my gratitude towards the society for lending me this opportunity to present a case. So the topic of my presentation today is uterine scar rupture and termination of intrauterine fetal death of 17 weeks gestation, which is a rare thing to encounter. My guide is Dr. Vidya Tarankar ma'am, Dr. Vijay Pawar sir, and Dr. Neha Jagdare ma'am. So here I proceed with the case. A 25 years old, gravida 2 paravan live 1 with previous lower segment cesarean section with 17 weeks of intrauterine fetal death. Patient was referred from Women's Hospital, Osmanabad for further management in view of termination of pregnancy. So she had been given trial for termination for 3 days, that is from 2nd of May till 4th of May, and then she was referred to Civil Hospital, Solapur on 5th of May. Patient presented to labor room with chief complaints of pain in abdomen since 2 days, and she specifically had complaints of excruciating pain 2 days back, and then the pain had decreased. I mean, it was in the milder form. Fever since 2 days and per vaginum bleeding since 2 days. These were the referral chits which had mentioned about the treatment given to her in detail. The patient is married 4 years back with a female child of 3 years old with previous lower segment cesarean section, which was done in view of non-progression of labor. She had regular menstrual cycles. Her last menstrual period was on 26th of Jan 2024 and her expected delivery date was 12th of October 2024. So the patient was admitted in Women's Hospital, Osmanabad on 24th of April 2024 in view of USG report suggestive of intrauterine fetal death of 17 weeks for termination. Patient had come with severe anemia. Her HB was around 7, WBC count 9,000 with neutrophils 88%. So she has been transfused with 2 Paxil volumes in Women's Hospital, Osmanabad there itself. And later on, she was given 6 days of antibiotics treatment and was started for termination. So her termination was initiated with tablet misoprostol. 400 micrograms of misoprostol was given twice in an interval of 3 to 4 hours. And thereafter, intracervical folius was done, which was removed 24 hours after 24 hours. So she was referred to Civil Hospital thereafter in view of further management. So when she came to labor room, she was brought to labor room with her relatives. She was conscious, oriented to time, place and person. Patient was weakly built. Pulse was around 160 per minute. BP was 100 by 70 mm of Hg. Saturation was 98% on room air. Respiratory rate was increased, that is 32 per minute. Temperature was 99.2 degree Fahrenheit. Pilar was present. Rest all findings were within normal level. On per abdo examination, on inspection, previous scar mark was present on the lower abdomen. On palpation, uterus couldn't be palpated. Abdomen was soft with mild tenderness. Distension was present. Fetal heart sounds were absent by handheld Doppler. On per speculum examination, active bleeding was present. On per vaginal examination, cervix was 1 centimeter dilated with clots in situ and 50% effaced. Frank PV bleeding was present. Her HB was around 10.1, platelets 4,60,000. WBC was significantly raised, that is 31,000 with neutrophils of 85%. INR was 1.03. Rest all lab values were within normal level. So we immediately shifted the patient to operation theatre for exploration under general anesthesia. So after opening the abdominal cavity, what just popped out were fetus and the placenta with clots. Foul smelling necrotic tissue was present, which was suggestive of old IUD. Total around 500 ml of hemoperitoneum was evacuated. So due to expulsion of the products of conceptus, the uterus has retracted and was situated deep into the pelvic cavity. So initially it was very difficult for us to trace the uterus due to multiple adhesive bands, and mental thickening was present as well. So with the guide of our expertise, that is Dr. Pawar sir, with the help of cervical manipulation, we anteverted the uterus, and it was possible for us to trace the uterus intra-abdominally. These were the product of conceptus which were evacuated from the abdominal cavity. Here is the short visual presentation of the abdominal cavity after evacuation of the product of conceptus. The omental thickening was present, and bowel loops were adhered to itself. A lot of slough and necrotic tissue was present as well. We evacuated the hemoperitoneum and cleared the cavity. In this visual presentation, we were able to trace the uterus and find the ruptured side. So after clearing all the slough and doing adhesiolysis, the uterus was traced, and the ruptured side could be seen on the old scar side. So an important point to note down here is that the ruptured side was not bleeding actively, as it was present on an old scar side, so which appeared to be fibrosed. So it was in our favor to manage the patient successfully. Here we could see the ruptured side. It was, unfortunately we couldn't provide good video because it was impossible to exteriorize the uterus. So bilayered suturing of the ruptured side of the uterus was done with the help of Vicryl number 1 and chromic catgut. Uterus was traced for any extension. Saline wash was given along with betadine. Hemostasis was achieved. Abdominal drain was kept. Intraoperatively, only 1 PCV and 2 FFP were given, as the patient's vitals were stable and no significant bleeding was present. She was kept on higher antibiotics and shifted to surgical trauma ICU for monitoring. She was then shifted to wards the very next day with stable vitals and her labs in improving trend. So we followed ERAS protocol, that is enhanced recovery after surgery protocol for the patient. This was the video of the patient after 24 hours. So ERAS protocol is to speed up the recovery time and minimize the duration of the hospital stay and also cost. This was the repaired uterus after suturing. The HPR reports of the patient were suggestive of retained infected products of conceptus with decidua showing acute inflammatory cell infiltrate. So the probable reason for rupture in the above case could be first is injudicious use of uterine stimulants. So as in above case, not much details were available regarding total use of misoprostol and other uterine stimulants. So this can be one reason why it might have led to a rupture of the uterus. Second is scarred uterus. So scarred uterus itself is a very big risk of causing rupture of uterus when induced with misoprostol. Next is infection. Now this case was old intrauterine fetal death, so which might have resulted in utero-infection, causing uterine musculature to lose its natural strength, resulting in rupture of the uterus easily after induction. So as said and proven, chorioamnionitis increases risk of rupture by 6-fold. So the possibility should be kept in mind before terminating the second trimester patients with intrauterine deaths. So uterine rupture, a rare life-threatening complication. So it's definitely a worst nightmare for an obstetrician. Rupture is usually seen in second trimester after induction for termination in a scarred uterus. The medical abortion, the most widely used method in our setup for medical abortion is usually the mifepristone, tablet mifepristone and misoprostol. So it came as an alternative for the dilatation and curettage, which caused more complications, resulting in around 50,000 to 1 lakh maternal deaths every year. So mifepristone is it has anti-progesterone action, whereas misoprostol, it causes uterine contractions, cervical softening and dilatation. The regimen what we follow is 200 mg of mifepristone is to be given 48 hours prior, followed by misoprostol 400 micrograms sublingually or pervaginally in an interval of 3 to 4 hours. So maximum 5 doses can be given, but even if after 5 doses the products fail to expel, we can repeat the regimen again after giving a gap of 12 hours. So this is the misoprostol FIGO regimen of misoprostol only, which was updated in 2017. So according to the gestational age, we decided the dose of misoprostol to be given to the patient. This is the mifepristone and misoprostol dosing chart of 2023, which was updated in 2023. So misoprostol is usually safe below 28 weeks with history of previous LSCS, and there is no as such contraindications for misoprostol in multigravidas as well. So how to prevent such dreaded complication? So first and foremost thing which I would like to mention here is to always to follow the standard guidelines for termination. Next is judicious use of stimulants. Injudicious use of stimulants, uterine stimulants, may lead to such kind of dreaded complications if not monitored properly. Next is, although it's a very rare complication, but close monitoring and careful examination of the patient in labor room, especially of second trimester termination, is mandatory. Tight monitoring of the patient in labor ward and determination of alarm signs can be one of the most critical reasons for preservation of uterus. And a long-term prevention strategy which we all can apply is control unindicated cesarean sections, so we can prevent the uterus from being scarred. So take-home message. We should never panic when we come across such kind of cases. Adequate resuscitation should be done. Airway breathing circulation protocol should be followed. Always to open the patient without any undue delay. Uterus should be traced. Never to take a decision of doing obstetric hysterectomy. And efforts should always be taken to conserve the uterus unless and until required. So watchful expectancy in post-operative period by monitoring vitals adequately. Higher antibiotics coverage to deal with the sepsis state. So to end my presentation, I would like to end it with a saying, there is no other organ quite like the uterus. If men had such an organ, they would brag about it. So should we. So as a good obstetrician, we should always do our best to save the uterus unless and until required. Thank you.
Thank you, Avantika, for such nice elaborative case presentation.
When we started misoprostol, there was a dictum that the misoprostol should not be used in scar uterus. So
Yes.
should we use it in the scar uterus or not? That is one thing. And you mentioned about judicious use of
Uterine stimulants. Yes,
Just
ma'am.
what are the stimulant which was given in this case? And what you mean by judicious?
Ma'am, actually
When
the
should we
patient-
start with oxytocin?
Patient was a referred case. She was being referred from Women's Hospital, Osmanabad. And whatever was mentioned on the referred sheet was just misoprostol 800 micrograms was given twice. 400 micrograms was given twice in an interval of 3 hours. So no other information was available to us whether oxytocin was given or any agents, Aviprime or anything else was given. So we don't have much information regarding that. Ma'am, according to the FIGO regimen, in the FIGO regimen it is mentioned, there is no such contraindication for misoprostol not to be used in scarred uterus. Thank you, ma'am.
Thank you. We should use judiciously uterine stimulants, and careful monitoring is needed. I would like to request Dr. Ghate Madam to felicitate Dr. Avantika. We are moving toward the second case presentation, presented by the Avantika Thomre, junior resident from Ashwini Kumbhari Rugnalaya, Solapur. She was going to present on a case of HELP syndrome with multi-organ dysfunction. She has done her MBBS from Nagpur with University Gold Medalist, late Dr. Leela Dubey Oration, Gold Medal in Obstetric and Gynecology, one publication in International Journal, and presented a paper and poster in various conferences. I invite Dr. Avantika to proceed further.
Good evening, respected teachers, senior members of the society, my dear friends. Myself, Dr. Avantika Thomre, junior resident, ARMCH Kumbhari, Solapur. I am presenting a case of HELP syndrome with multi-organ dysfunction under the guidance of Dr. Vrunda Chaudhary, Professor and Head, Department of OBGY, ARMCH Kumbhari, and Dr. Shraddha Tadkar, Senior OBGY Resident, Department of OBGY, ARMCH Kumbhari. 19 years old primary gravida with 8 months of amenorrhea, she was referred to us in an unconscious intubated state with Ryle's tube and Foley's catheter in C2 with the provisional diagnosis of antepartum eclampsia with intrauterine death with HELP syndrome and DIC. As narrated by the relatives, early in the morning, patient developed sudden onset severe headache, burning and pain in the epigastric region, blurring of visions, hematemesis, convulsion, loss of consciousness. She was rushed to the hospital where primary care was given and investigations were advised, and she was referred to a higher center. Her primary BP recorded at the referring hospital was 220 by 130 millimeters of mercury, wherein the patient was intubated. She was started on injection levetiracetam, injection labetalol, tablet nifedipine was given, and patient was referred to our hospital. Upon receiving the patient under the combined care of obstetrics gynecology department and medicine department, patient was admitted in the ICU. Further detailed history revealed it to be a spontaneous conception with a period of gestation of 32 weeks. She was a registered case and her antenatal period was uneventful. Patient was normotensive throughout pregnancy and documentation revealed that she was not on any antihypertensive or any other medications. At 32 weeks of gestation, she developed sudden manifestations of eclampsia. On examination, the general condition, the patient was unconscious. Her GCS was E2, VT, M1. That is, patient was responding to deep painful stimulus and there was no motor activity. Patient was intubated. Her pupils were mid-dilated, non-responding to light. Tone was reduced in all 4 limbs, deep tendon reflexes were exaggerated and nasal bead was present. Her saturation was 95% on PRVC mode with 100% FiO2. She was afebrile, pulse rate of 140 beats per minute, low in volume. Blood pressure was 190 by 130 millimeters of mercury. Significant pallor was present, icterus was present, periorbital edema was present, bilateral pedal pitting edema present up to the knee. Gross hematuria was noted, endotracheal tube was blocked and hence re-intubation was performed. RS and CVS examinations were normal. Per abdomen examination revealed abdominal wall edema, fundal height of 28 to 30 weeks, uterus was relaxed, cephalic presentation, fetal heart sounds could not be localized with the help of handheld Doppler. Per vaginal examination revealed patient not to be in active labor. After sending all necessary investigation, it was found that HB was 18.6, platelets were 64,000, peripheral smear revealed schistocytes present, urine albumin was 4+, creatinine was 1.7. Her coagulation profile was deranged and LDH was significantly raised, D-dimer raised, bilirubin was significantly raised, and SGOT and SGPT were also markedly deranged. Obstetric ultrasound revealed intrauterine death of 29 to 30 weeks with Spalding sign positive. Ultrasound abdomen revealed mild ascites, renal changes suggestive of acute kidney injury. CT brain revealed changes suggestive of posterior reversible encephalopathy syndrome. 2D echo revealed ejection fraction of 60%. Her IVC was prolapse, dehydration present, grade 2 diastolic dysfunction with no valvular pathology. Fundoscopy showed a grade 3 hypertensive retinopathy. We reached to a diagnosis of antepartum eclampsia with intrauterine death, with disseminated intravascular coagulation, with HELP syndrome, with PRESS syndrome, with multiple organ dysfunction. On consultation with the physician, ventilatory support was continued. 4 gram magnesium sulfate IV stat dose was given and further doses of magnesium sulfate were withheld due to deranged RFT and gross hematuria. Anticonvulsant injection levetiracetam 500 mg was started. Patient was started on injection mannitol 100 ml 6 hourly. Dehydration correction was done with adequate fluid therapy. 4 units of fresh frozen plasma were transfused. Injection labetalol infusion was started, soda bicarb started, higher antibiotics were started. On day 2, the patient went into spontaneous labor. It was augmented with the help of oxytocin and she delivered a 1.6 kg macerated stillborn baby. The placenta separated normally. There was no evidence of any bleeding or postpartum hemorrhage and the uterus was well retracted. On day 3, her GCS started to improve, eye opening to pain, abnormal flexion movements were present. Ventilatory support was continued. Her hemoglobin dropped to 8.5, 1 point PCV was transfused. Platelets significantly dropped to 22,000 and hence 3 units of RDP were transfused. Further on day 4 to day 6, her GCS improved further. She was kept on BiPAP mode of ventilator and subsequently weaned off, but because of aspiration pneumonitis was suspected and the patient was reintubated again. Injection mannitol was withheld on day 5. HB further dropped to 6.8, 1 point PCV was transfused again and her platelet now started to improve. Further day 7 to day 8, high grade fever spikes were noted, cultures sent, fever profile sent, accordingly antibiotics and hydration correction was done, physiotherapy continued. By day 9, patient was conscious, cooperative and well oriented. Day 10, patient was shifted to ward. Hypertension was controlled on tablet nifedipine 20 mg TDS. By day 15, patient was discharged tablet nifedipine 20 BD. By that time, hemoglobin, coagulation profile, LFT and RFT all came back to normal levels. So this was a case of HELP syndrome, which stands for hemolysis, elevated liver enzymes and low platelet counts. It is a complication or progression of severe preeclampsia. The diagnostic criteria that we use is hemolysis in the form of abnormal blood smear, elevated bilirubin, low serum haptoglobin, increased LDH more than 600, elevated liver enzyme twice the upper limit of normal and low platelet counts below 1 lakh. The presentation usually is in the form of nausea and vomiting, right upper quadrant or epigastric pain, mild to severe hypertension and significant proteinuria. Our patient had an HB of 18.6, which was because of significant amount of hemoconcentration. Mississippi and Tennessee system are used for the classification of PRESS syndrome. Our patient belonged to class 2, further class 1 of Mississippi because the platelets were 22,000 and complete syndrome because all the parameters, that is AST, ALT, LDH and platelets were deranged according to the Tennessee system. Various maternal morbidities like abruptio placenta, DIC, pulmonary edema, acute renal failure, adult respiratory distress syndrome and death are the morbidities associated with HELP, and perinatal morbidities like prematurity, RDS, intracranial hemorrhage, necrotizing enterocolitis are also associated. Management is usually supportive. They require ventilatory support, vasopressors, monitoring of the volume status and nutritional support. Such patients are to be managed at tertiary care centers, and immediate transfer from a primary to tertiary healthcare center plays a pivotal role in management of such patients. Management principles are based on termination of pregnancy, control or prevention of convulsions with the help of magnesium sulfate, antihypertensive medication, fluid therapy, adequate use of blood and blood product administration. HB less than 7 or hematuria, suspected abruption or chymosis are the indications of red cell transfusion. Any actively bleeding patient with any degree of thrombocytopenia should be transfused with platelets, and coexisting DIC may need fresh frozen plasma and cryoprecipitate. Recent studies have suggested a role of corticosteroids in reducing hospital ICU stay and blood transfusion rate, but it is not significantly associated with better maternal mortality and overall morbidity. PRESS, it is a clinico-neuroradiological syndrome associated with hypertensive encephalopathy and eclampsia. The patients present with headache, lethargy, somnolence, visual disturbances and seizures. They have a radiological finding of cerebral white matter edema. The pathophysiology is because of the altered breakdown of cerebral vascular autoregulatory mechanism, leading to hyperperfusion and edema formation, usually in the posterior part of the brain. Following other radiological imaging, where in MRI, hyperintense lesions are seen in the posterior lesions, external capsule and basal ganglia, and CT scan shows hypodense lesions. Again, the PRESS management principles are injection mannitol, which plays a magical role to decrease the cerebral edema, control of convulsion, and leads to dramatical clinical improvement. Injection mannitol 100 ml IV, 4 to 6 hourly, and slowly tapered if there are no convulsions. Patient education plays a pivotal role in preventing the occurrence of HELP or PRESS in subsequent pregnancies by maintaining a healthy lifestyle, educating the patient by preventing diseases like hypertension and diabetes. Regular exercise should be followed. Routine prenatal care and lab testing in the subsequent pregnancies may help prevent and curtail preeclampsia, eclampsia, PRESS and HELP syndrome. These were my references. Thank you.
Any questions? Any question?
Where was antenatal checkup done?
Ma'am,
Because immediately she went into the eclampsia, PRESS, whether regular antenatal checkup or the checkup is wrong, 120 by 80 BP all the time.
Ma'am, the patient was a registered case outside.
Outside where? Where? Why this happened? We are having so many things to predict and prevent preeclampsia.
When I went through the case, the blood pressure of 140/90 was taken very casually by the center where she was registered. So she was only given sedatives and no antihypertensives and no care was taken. And it's a well-known fact that 140/90 can also lead to so many complications in the patient.
Use of digital BP monitors, does it have any?
My personal experience about digital BP monitoring is worst. Okay. So we still, I have been for my checkup going to cardiologists in Solapur, and all of them have been recording my blood pressure only with the sphygmomanometer and not with the digital monitor.
The patient can have a convulsion and can go in the press. It is not that they should have blood pressure for a very long time. You never know. It is very tricky question. That single convulsion also can make the patient. Even sometimes there is no edema also, and the patient can get a convulsion and patient go in the press.
Sir, as there is a patient is
In this patient there is IUFD, so the all complications are there because of high blood pressure that was not recorded properly or not monitoring properly, and after IUFD all this HELP syndrome and all this, so the blood pressure might be higher for more than 3 weeks to 1 month. That's what I think.
Not necessary for the blood pressure to remain high for a long time. Okay, even a short duration of raised blood pressure up to 140/90 can cause all these problems. And I would say, rather than intrauterine fetal death causing these problems, her status of unconsciousness and her hypoxic status might have led to intrauterine death because there was no abruption in this case.
So we have been. Some of the patients who have 90/60 in early pregnancy, they have convulsions with 120/80 also I have seen.
Sir, in the cases we get at a tertiary referral, now the case, not just one parameter, the multiple parameters should be considered, and especially the proteinuria with hypertension is a bad combination. And for those patients who don't fit in the picture of typical preeclampsia, which actually get relieved by after delivery immediately. If the patient doesn't get relief of hypertension and the complications within first 72 hours, there is something else at the play in that. And we have been doing now the immunological profiles of these patients, and a lot of patients are turning out to be ANA positive, APLA, SLE, which were unrecognized. And for some patients, when we recognize it earlier, we have started them with either low molecular weight or steroid or azathioprine, depending upon the underlying problem. The further course is miraculous. They don't even develop hypertension, they don't even develop FGR. So I think the patients which don't fit in the typical picture, we should investigate earlier.
Sir, what is the role of magnesium? Loading dose of 4 milligram. Already patient have bilirubin raised, liver enzyme, creatinine raised.
She had all these things raised. Now, before subjecting her to her investigations, we were really not knowing what her renal status was. So the loading dose was given. And once you give the loading dose, and if you find that the renal function is poor, see, the magnesium is being anyway excreted by the kidneys. So the magnesium levels are going to get stabilized in the blood, and adding further dose, giving further dose of magnesium sulfate would add to magnesium toxicity. That's why the further dose of magnesium sulfate was withheld in this case. Yeah, and hematuria becomes a direct contraindication for continuing magnesium sulfate in patients with eclampsia.
Thank you, Dr. Avantika.
Thank you, ma'am.
I would like to request Dr. Ghate madam to felicitate Dr. Avantika. To proceed further, I handed mic to Dr. Amruta.
Good evening, everyone. After these two interesting cases, we are going to have a session of panel discussion. I would like to invite Dr. Bakul Jagirdar madam to moderate the panel. And as panelists, I would like to invite Dr. Rajiv Dabde sir, Dr. Vijay Pawar sir, Dr. Chandrakant, and Dr. Sadhna Deshmukh madam. Dr. Bakul Jagirdar madam is a consultant obstetrician and gynecologist at Chitade Clinic Private Limited. She's practicing since past 15 years. She's consultant obstetrician and gynecologist at Ashwini Sahkari Rugnalaya since past 3 years. She's MBBS and MD from VM Medical College, Solapur. She's secured gold medal in MD. She's done many presentations in local and state conferences. And her special interests are high-risk pregnancy and fetal medicine. Dr. Sadhna Deshmukh madam is a practicing obstetrician and gynecologist since past 33 years at Suyash Nursing Home and Ashwini Hospital, Solapur. She is a trained sonologist and she has great passion in obstetrics. Her hobbies are music, singing and event management. Dr. Chandrakant Jadhav is MS from VMGMC Solapur and he is a director at Sanjeevani Nursing Home, Solapur. Dr. Vijay Pawar sir is a consultant at SIMS Fertility Center, Solapur. He is associate professor at VMGMC Solapur and unit in charge. He is ex-clinical associate at Regenesis Center for ART, endoscopy and fetal medicine. He has done his fellowship in ART and minimal access surgery. So I would request Dr. Bakul madam to start with the panel discussion.
ग्रुपमध्ये पण अनाऊन्स केलं तर आहे
This is the QR code. Please, during this panel discussion, we will be taking audience vote also. So please, if you can scan it and log into the group, then you will be able to participate in the discussion as well. I request all the audience to participate. Good evening, respected teachers, the panelists, and my dear friends. Today, we are conducting a very important panel discussion on a topic which is very close to our obstetrician's heart, that is postpartum hemorrhage. Before we start the discussion, I would like to share a very short, interesting story with you. When we were thinking of the panelists for this panel discussion during the last conference, I actually wanted Dabde sir to be there on the panel. And because he is our Taranhar at Ashwini, I have seen him very close, up close with very critical situation, with a steadfast mind and the steadiest hands I have seen. So I wanted him to enlighten us and give us the inputs, but at that time he refused. But as Shah Rukh Khan said, अगर किसी चीज़ को सच्चे दिल से चाहो तो पूरी कायनात उसे हासिल करने में लग जाती है. And true to that, the panel discussion only got cancelled. Just so that he will be there today on the stage to guide us. So let's start with the discussion. As an obstetrician, when we hear the word postpartum hemorrhage, our pulse starts racing, the BP shoots up the roof, and the perspiration, we get the beads of perspiration on our forehead. And we are scared. Why it is so? We are scared of things which we are not prepared for. And many of the times, this PPH knocks at our door when we are least prepared, and we don't have a fallback plan and a second line strategy. And that causes a devastating trail of mishaps for the patient, for the obstetrician, for the society at large. So it becomes a very, very, very multifold problem. So it is very important to address this problem very, very seriously, so that not a single maternal life should be lost for a preventable cause like postpartum hemorrhage. Now, for prevention, for reducing the incidence of postpartum hemorrhage, it is necessary to, I say, assess, prevent, and act swiftly for the earliest detection and management to reduce the complication and maternal mortality. And for that, let us come to the prevention part first. In prevention, the risk assessment is the most important thing. So, risk assessment during the antenatal period and during the intranatal period, the active management of third stage of labor, we all know that these are the two pillars of prevention of postpartum hemorrhage. Now, this question is open to all panelists. Who is at the risk of PPH in your opinion?
I think every patient is at a risk of PPH.
Yes, ma'am. We say that when we say every patient is at the risk of PPH, we say it, but when a patient comes to the, next patient comes to the labor room, she's a primary, she's a full-term low-risk patient with a good HB of 12 gram, how many of us are going to think that she's a high-risk patient? So I would request all of us, as she said, that every patient, every parturient woman is at the risk of PPH. Though God has given her additional blood volume to sustain this average blood loss during the pregnancy, we have to figure out what is not average for her. And for that, we have to be very, very vigilant. So there are some women who are at higher risk than the other women. So I want to ask Dr. Vijay Pawar, who are the patients are at the higher risk of postpartum hemorrhage? I think your mic is not working.
Madam has already said that all patients are at risk of PPH. This is working. So all patients are at risk of PPH, but if you want to categorize, we can categorize it into the our obstetric causes where we have anemia, PIH. So if you take any textbook of your obstetrics, all your patients in all the high risk, the index, every patient is at risk. So you have anemia, you have PIH, polyhydramnios, okay, twin pregnancy, diabetes mellitus with pregnancy, heart disease. So these are all cases that will come, and previous LSS obviously, any scarred uterus, maybe myomectomy, all these patients will come under risk, and there will be some non-obstetric causes where these patients, especially patients with any medical disorder in pregnancy, like we have thrombocytopenia, DIC, any fever for that matter in pregnancy. So jaundice, very common, HELP syndrome. So all these patients are at risk. So those are the cases that I would suggest.
Yes, sir. So as sir said, there are some obstetric and there are some medical problems with the patients which put them at the higher risk of postpartum hemorrhage. So we should probably tag them early on in the antenatal OPD itself on the card, and we should train our staff to inform us if such patient comes that Madam T high risk wali ali, so that we will be quick in our response. We will go see her immediately, and so on and so forth. So we have to act in the antenatal OPD itself and not wait for the postpartum hemorrhage to happen. Now, Dr. Sadhana, if such a patient who is a high risk for postpartum hemorrhage, like as sir said, she is a preeclampsia or GDM, what are the precautions we should take when she comes in labor?
First of all, I would like to tell you what I follow. In the OPD paper, I always write down the high risk factor on the top of the page, so that the in capital letters. And number two, we have made a board in our labor room and OT where we write all patient details, and if there is any high risk factor, we are supposed to write there. Our junior staffs are trained to write that, so that immediately it is highlighted and they can take precautions. First of all, when the patient comes, every patient I send at least one PCV in a low risk patient and 2 PCV and 1 FFP as soon as the Gelco is instilled. So this is our protocol. It hardly takes 150 rupees for the sample, the cost of cross-matching one. Moreover, the sample can be used for multiple cross-matchings, 5 or 6 maybe FFPs. So that is one thing. I think it is prevention. I do it for all the patients. Only the number of this ready differs, and depending on we should have the fresh CBC. And we should follow some do's and don'ts in those patients, and we have to instruct the sisters properly that what all things can happen this and what things where it can go wrong. So
yes, precisely. This is a very important point that you have brought up, that arrangement of products when she comes in labor, even for low risk patients. And I think many of us may not agree with this, and many of us would say that this is like little too much. This might be a response, but this will come in the panel discussion later, that if at all the patient lands up with a major PPH, the most important factor, that the most important thing we can do is the hemostatic resuscitation, not just the fluid replacement. And for that, if you don't have the hemostatic products, how we are going to prevent that? So probably, as she said, it is just 150 to 200 rupees. If we book a product, it doesn't mean that we are going to transfuse it. So just putting aside 200 rupees is not going to be so much of a harm, I think. So I agree with you over there. What about the other panelists?
Yeah. What I have heard in a similar, one of the conferences when similar discussion was going on, it was Dr. Mahale who asked a question to the panelist. So we are all scared of litigations. So which patient is high risk for litigation? And then Dr. Girish Kumtikar was there. He said, every patient is a potential litigator. Okay. So we have to fill up our all the forms and case papers and make notes properly, so that whatever the litigations one may make, we are safe. Then he said, that's right. So who are the patients who are likely to land into PPH? As he said, every patient is likely to land into PPH. And he said, if the patient is coming to you for delivery, expecting you to deliver her well and send her home well, okay, why not arrange blood products at the time of admission? Then one of the parents asked him, Sir, पण सगळ्यांना arrange करायचं का? Sir, then sir said, you tell the patient, मी एकटाच का घाबरू, तू पण थोडं घाबर ना. And they would be thankful to you if you are really predicted that and arranged. Only thing I beg to differ from Sadhana that at least 2 Paxilus and 2 FFP should be kept ready. Okay. For all
In or only high
if
risk?
a patient requires blood transfusion, 1 PCV is not sufficient. If a patient requires blood transfusion, 1 FFP is not sufficient. She has to require 2 points both.
Can I say something? Yeah, I agree with him. Only thing is that we have a sample and we have, in case there is slight, we can just call the blood bank and ask them to cross-match more samples.
Okay, that's not the point of discussion today, how many bottles should be arranged. So it's up to you how to make you safe. Okay. So if you say, no, I have one of relatives who is a good advocate, so I do not worry about writing the notes properly. Okay. So it's saying something like that. But if at all you want to protect yourself, and if the patient is going to pay your bill at the end, okay, and that amount which they pay for arranging the blood products is really meager as compared to what they have to pay as the hospital bill. That's what I would stress rather than just making the comment.
Okay, so that might be a take home for us for today.
Chandrakant has to say something.
Madam, other scenario become worst when there is a no risk factors.
Yeah.
The patients with risk factors, we counsel them because you have twin pregnancy, you have polyhydramnios, you are at a risk of PPH. But the patients with no risk factors, full-term pregnancy, no PIH, no twins, nothing is there. And when she bleeds, then there is a very
Yes, that is very true,
problem.
actually. 1 or 2 more things I want to insist here is personal counseling in such cases is very important. Madam Alia, Madam ni bagitlan amchashi bolya makes a big difference. So high risk patients when they when they come to the labor room in labor, it is
Some places it could be sir also coming and seeing the patient.
I am so sorry, sir. So counseling them personally. Another thing is we should make a rule in our labor room that only green gelco for all the patients who are coming in labor, and grey gelco immediately goes in if the first bottle of blood starts. If we train the staff like that, they will do it without us telling them next time. Also, the baseline pulse and blood pressure, we have to know for sure about the baseline pulse and blood pressure. If her baseline pulse was 60 and now it is 100, means differently from her baseline was 90 and now it is 100. So the baseline pulse and blood pressure recording majority is done by staff, but for such high risk patients, we have to train our staff to really do it diligently and inform to us. Probably some staff training will go a long way for us, and I think be paranoid. There is no point in say don't worry, be happy. No, be paranoid. When such situations come, be paranoid, think for worst case scenarios, be prepared for everything. I think that is something which saves us. When we are prepared, we tend to fail lesser. So now we have assessed the patient, we have assessed the risk, we have tagged them in the antenatal period. When they come to labor room, we know what to do with them now. Now when they deliver, I think when they deliver, the most important thing that is going to save her from PPH is the active management of third stage of labor. Now I want to ask Dabde sir, because especially for the benefit of postgraduate students who are over here, different guidelines promote different components of the active management of third stage, like delivery of uterotonics at the anterior shoulder delivery or after the delivery of the baby. Control cord traction should or should not be given. Bimanual uterine massage should be given routinely for prevention of PPH or only if the PPH is happening for treatment of PPH, or early versus delayed cord clamping. Sir, what are the actual components of active management of third stage?
There are clear-cut guidelines from the WHO that active management of third stage of labor should be utilized by the persons who are trained. Okay. And the options some parts have been deleted from active management of third stage of labor at the places where no trained personnel are available. So the difference in the guidelines is just this. The main guideline of AMTSS still remains the same, use of oxytocin and control cord traction, because they have modified this because at some health centers where the expertise is not available, this control cord traction may be misunderstood what is control cord traction, and that can lead to complications. That's why they have deleted control cord traction from the areas where skilled personnel are not available.
Okay, sir.
And similarly, the uterine massage. Some people would massage it so much as to cause pain in the intra-abdominal wall. So massage is just given to make sure that the uterus is retracted. Yeah.
Okay.
And not to expel the blood clots collected in the uterine cavity.
Yes, sir.
That's the change that has been made.
Can you comment about a refocused approach suggested by the SOG and WHO, which includes further few more things? Have you? There is a refocused approach to the active management of third stage of labor, which is in combination WHO with ICOG. They have suggested few more things, like inclusion of the postpartum vigilance in the active management of third stage of labor every 15 minutes for 2 hours, what we say as a fourth stage.
No, that is to say that they have included what is called as fourth stage of labor, actually, 2 hours post-delivery. And this fourth stage of labor is more important than the third stage of labor, they say. Though we all know that third stage is such a treacherous stage of labor and it's very vital. Okay. But as you say, with the advent of carbetocin, actually, which has a longer half-life, initially when fourth stage of labor was being monitored, it was said that you have to continuously give oxytocin drip for those 2 hours. Okay, with 10 units per hour. Okay. But now with carbetocin coming in the market, that continuous drip and monitoring has little less value, as I suppose.
Okay. And they have also included...
Yeah, please.
Sorry.
And this is what the WHO manual on PPH says. That I have posted WHO manual on PPH on the academic groups. So if we are missing anything from the discussion, everybody can go through that to update themselves.
That's very kind of you, sir. Thank you so much. And they have actually added oxytocin quality control also, the cold chain.
Definitely, because that's for countries like us and the African countries where temperature is very high. So oxytocin actually should be stored in not as a absolute cold chain, but it should be stored at cool temperature. Okay, room temperature. Even our room temperatures raise so much that the oxytocin loses its potency. And the booklet also emphasizes that those institutions where they are having good number of deliveries happening, they would be replacing the oxytocin injections. They need not worry about this because there is not prolonged exposure of this oxytocin to the higher temperatures so as to lose the potency. But where the number of deliveries are less or the replacement of the oxytocin ampoules is less frequent, they should be careful about it.
So I think that is also something important. I don't know how many of us are keeping watch on oxytocin temperature, but we should start doing it if we are not doing it. Now, we have done everything, we have done our active management of third stage, but the patient continues to bleed and she lands up with postpartum hemorrhage. It is very important to ascertain the cause of this postpartum hemorrhage. The 4Ts, historically we know that tone, tissue, trauma and thrombin. Interestingly, Royal College of Australia and New Zealand have added another 2 Ts like theatre and training. What that might be?
Those are developed countries and those are their problems. Okay, so we need not worry about that. But yes, training module is absolutely followed in their curriculum too. Okay, and because now for the information of those who have already passed out, there is change in the medical education curriculum, and the undergraduates and postgraduates are being trained with such modules to like PPH module. Okay, that has to be, that is being implemented in our country too.
Yes, and definitely the training, because I have done my high-risk fellowship last year only from VM Government Medical College, and Pawar sir and Tirankar ma'am Pawar sir and the team is teaching postgraduate students about the systematic devascularization and even the internal iliac ligations. They have taught me also the internal iliac ligation. That makes such a big difference to know that you can do it. And even no matter how quickly the help comes, there even hurry takes time. It takes 15 to 20 minutes for the person to come. In between, she bleeds 2 liters. So this internal iliac ligation we should have a training for. And I'm so happy that our teaching institutes are teaching now PG students all these things. So now coming to the management of atonic PPH, we all know that the first comes the medical management, then the conservative non-surgical, then the conservative surgical with stitches and all, and then the definitive surgery. Now coming to the medical management, we all know that the first line drug is oxytocin, everybody is using it, I totally agree. Now I want us to focus on the second line drug, because no two guidelines actually have a uniform opinion about the second line drug. The effigofoxia are still with the methergine, but WHO is now recommending carbetocin as a second line drug, and always it says that they are resource poor countries, and I don't know how it turned up on the second number, but they have done it. Because they have done it, the scenario is changing. So I want to ask, actually this can be an open question for the panel, what should be the second line drug in your opinion? Now if we see that oxytocin minimum 100 rupees, all these things, and methergine is 16 rupees. So why not methergine? Why this is being painted as a villain? And do you agree with this?
I think I would go with methergine, because we have been used in even as a first line drug wherever it is not contraindicated. Methergine is a very good drug, heat stable, especially in Solapur. Oxytocin, I don't think so many, when we are using in medical college oxytocin, lot of times inductions we do, it fails. We use oxytocin and still patient is bleeding. This happens because most of the time the cold chain is not maintained, which is not in our hands. So that is a problem. You will keep the injection in cool temperature, as sir has said, but from where the injection you have procured, whether that cold chain is maintained, like we use for in IVF for gonadotropins. So there will be lot of batch to batch variability with oxytocin. With methergine it is not there. So methergine is a good drug. Other drug that we have is misoprostol. So these two drugs are so good. So I think lot of people like we used to use carboprostromethamine before prostaglandin. So that use of that injection has very much reduced nowadays. So misoprostol and methergine depending. And what WHO is saying is that carbopros, maybe they are getting more this carbetocin. I think lot of CMEs are sponsored by carbetocin nowadays, and we all get brainwashed with carbetocin. So everybody is now using first line carbetocin, and they are actually promoting carbetocin with all our anesthetists. So your anesthetist, every anesthetist you go in Solapur, the carbetocin there. You see, just observe. They will first think the drug. Previously they used to give oxytocin. Now suddenly they want to give carbetocin. Every OT they insist that you should have carbetocin.
But anesthetic conferences are not backed up by carbetocin.
No. But you see, obstetrician, everybody is now after 5-6 years again you will be on the same thing. But if you see, misoprostol is so time-tested drug. What the stability it is having, you can keep it at room temperature, and when WHO recommends, it has to go to your not even city level, at the taluka and no village level also it is very good. So methergine at village level very good. Here you have a patient is rich, you want to give carbetocin, there's no problem. It is a good wonderful drug, there's no problem with carbetocin.
I think methergine has a unique action that it causes the tetanic contractions
So
of lower segment
will be
also.
So anybody wants to say anything different?
And second thing is misoprostol. If she doesn't bleed, not in hypotension, it is good to give her sublingually. Per rectal absorption is more hectic, but sublingual misoprostol is good option.
To
But
give your
interestingly,
PPH
the
tablet so
WHO
easy, just put it under a sublingual.
And
It's so
it's-
easy.
But interestingly, the WHO says that misoprostol should be used in the PHC setup when there is no IV, probably no IV access and no trained
If you
staff.
compare all the drugs according to the efficacy, all are equally effective. The cost-wise and the pharmacodynamics and kinetics differ. So whatever is available, I think it's not. This should be the second line and this should. But whenever the PPH happens, all of us give all drugs.
All drugs.
So because you don't know which drug will act and which will not
With
act.
injection,
But
pause
most
and-
important, if the bleeding is from the lower uterine segment, the oxytocin will not work.
Yes.
So lower uterine segment bleeding, methargine will work, misoprostol will work, and your carboprost will work. So those drugs are means in your armamentarium you should have all the drugs with you. You can't fight the battle halfway.
Yeah, but then we are talking about the second line. So let's come back to
That's
that.
what I am telling you. Whenever there is no second line, you will give all drugs that are available. No gynecologist will wait for only. He'll just wait for misoprostol, wait for action, and then he'll give me. Methargine has so fast action.
What
If it
was
is
the
not
audience
contracted,
poll?
what is the problem?
Yeah. What was the audience poll, Chedars? What did audience say? Did they say anything?
Hi.
First. So everybody with I like that. Me too. I am also with that.
I just missed.
Audience, there was a question for audience, and the maximum vote goes to methargine from the audience.
Here, I would like to comment on second generation drug, okay? Because me and my son, both the generations are practicing under one roof. No, this is a practical thing I want to say. Maybe the young people will agree. He says, no, you when you are spending so much, why not carbetocin? Carbetocin, of course, he's using as a primary line. I used to use methargine and keep 600 milligram misoprostol during the time of suturing.
He's
That
rich,
was-
ma'am.
Yeah, so that is difference.
He's rich, that's what I'm saying.
So that is working well. So why we are changing? Because just some new drug has come, we are been brainwashed. No, that
Yes,
is
I
because
agree.
that generation has not, the new generation has not used methargine.
Yes.
So they have not practiced.
So,
but those who are doing in VM Medical College, they all are using methargine only. So in government sector, methargine cheapest drug, easily
drug,
available.
yes, I
2
agree.
rupees it is actually. If you take from the generic market, it is not more than 2 or 3 rupees.
Yes.
So volume wise, methargine you cannot compare.
No, we-
Unless until it is contraindicated in that patient.
When we are talking about second line drug, everybody agrees that oxytocin is the first line.
Yes, yes.
So it has been given as prophylactic only. Okay, in active management of third stage.
No, but
and,
we are
and
talking
then when the
about-
bleeding starts, bleeding continues, or you notice that there is a PPH, then you are thinking about which drug to be used. One thing has to go out of our mind that carbetocin is more effective than methyl ergometrin. No, that's not the case. Methyl ergometrin is a powerful uterotonic drug than carbetocin. At the same time, carbetocin has a prolonged half-life. So it will act for a long time as compared to methyl ergometrin. That's the clear difference we must
And
understand.
one more thing important, if the patient has been induced with oxytocin or a patient has already been exposed to a lot of oxytocin in the first and second stage of labor, those patient ते युट्रस म्हणजे कुर्डुकर सरांच्या भाषेत वांड म्हणायचे सर त्याला वांड it will always, the uterus will always behave opposite what you want. So whenever you want to contract, it will relax, and when you want it to relax, it will contract. So that is what Kurdukar sir used to always say. So oxytocin, if you have used a lot of oxytocin, especially for induction of labor, prolonged use in the first and second stage of labor, then I don't think oxytocin is the first line of drug. Then you have to go for methargine. And if you fix a protocol in your, means everybody has a protocol, whatever, like methargine is a very, very wonderful drug, and unnecessary carbetocin has been marketed more.
So
That
I
is
just
what
wanted
feel.
to bring it on platform, that's it.
Half-life of oxytocin is 5 minutes. So even if you are induced with oxytocin, you are giving oxytocin, you can use carbetocin.
But the receptor saturation, we don't know
How much? But still it acts. We have seen
No,
actually.
I am not saying
it acts on the same
if
receptors,
the
that is
exposure
true.
is, if
Oxytocin, it's only half.
Carbetocin also acts on the
so
same
you can use
receptors.
it.
Yeah,
No, it is.
the point of discussion is you should not, or there is no point in using oxytocin and carbetocin at the same time.
Yes.
But if
And
you have
not at the
already,
same
if you have
time-
already given oxytocin, then but still if she is bleeding, you can give carbetocin.
no, we can give, there is no
Oxytocin,
problem.
ma'am,
I am just telling you this from experience that if you have
Nahi,
used
oxytocin,
oxytocin during your induction of labor, most of the times you will require another drug. That is there. You will require methargine, you will require miso. Problem is in private we are using all drugs. थोड़ा bleeding झालं की misoprostol पण द्या and nobody will deny that. We give because it is priority. It doesn't matter दोन्ही द्या ना काय, because mechanism of actions are different. They act on different places, so modes of actions are different. So there is
And,
nothing wrong,
yeah.
nothing is specific. What I am pointing out is that if the patient is for induction of labor or prolonged labor, those are cases where it is going to land in PPH. So there you use methargine or misoprostol prophylactically also.
So it would be good.
So that's what I want to tell.
Yeah. So it would
Don't
be.
wait for PPH to happen,
Sir,
especially atonic PPH should not happen.
So thing is that the pitocin has a very short half-life. That is when you are giving pitocin for the induction of labor.
Yeah, so that's why we are giving
till
it
patient
Well,
delivers.
I agree, sir. I got your point. I agree. But
so
the point
that we
is,
can give a carbitocin
But the
because
point-
the receptors are free at that
but
time.
the point is, when we use oxytocin, when we use carbitocin in PPH, it is never that we have not used oxytocin and directly went for carbitocin. We have already used 40 units of oxytocin that is already in the system. How it is going to go out unless you are going to forget about the PPH for another 30 minutes, which doesn't happen. So carbitocin and oxytocin are going to act on the same receptors. So why give the same family drugs?
No, it's the other way around. If you have used oxytocin, you can still give carbitocin. But if you have administered carbitocin, oxytocin has no role.
Yes. Okay, so I think that is a very good take home from that. And well, lot of this thing, the next slides were included in our discussion, so I will skip those slides. Carbitocin versus oxytocin and all. So this was again the questions for audience, for which I think they have already participated in this. Okay, so everybody is saying yes for oxytocin storage 2 to 8 degrees. Are you using carbitocin as a prophylactic drug? Well, no. Only in the treatment of, I think we are all good. So, do you use tablet misoprostol? Yes, even I use the, sir, it is, I think, really good, as Pawar sir said. So, misoprostol for prevention. So, I am happy that we are all on the same page. What is the role of injection, Dr. Pawar sir?
Just for the benefit of postgraduates, I want to mention that in their exams, if there is such a question asked whether you would use misoprostol or you would use carboprostol and methyl ergometrin. Misoprostol is to be used in low resource settings. Okay, that's to be clear, where the eyes are conducting the deliveries and there is nobody to administer the parenteral drugs. In those cases, misoprostol definitely has a role. Okay, and instead of giving orally, per rectal if they keep, is also equally effective. But where facilities are available, misoprostol is not a drug of choice to be used.
Yes. So the practicality is one thing, but I think in the exams, so what sir is saying that stick to guidelines, ज्याचे तुम्ही references देऊ शकता विचारलं तर. So I want to come to tranexamic acid. What do you think, sir? Dabde sir, what is the role of tranexamic acid in
Tranexamic acid definitely has a role in minimizing the bleeding, but there is a big but. The but is you should know that there is no hematological disorder in this particular patient. Because if there is a thrombin deficiency in those patients, tranexamic acid can cause havoc. Okay, it can cause embolism, clot embolism. So, but though that's a rare entity. Okay.
But how would you recognize that this patient is of?
If you know that patient is having some hematology, you are not supposed to use that tranexamic. That's most important.
Okay.
But yes, definitely it has a role, whether it's delivery or cesarean section. Tranexamic acid has a definite role, and it is proved in WHO manual that it reduces the blood loss.
incidence of PPH more after induction of labor.
Yes, induction of labor we know.
Anyway, she doesn't require mic.
As already it has been discussed, induction of labor, we know that the uterus which is contracted after a stimulation may go into atomicity and PPH. So we are always giving prophylactic, as we have already discussed, oxytocin and misoprostol tablets. So
And here we are talking about induction of labor and augmentation of labor. Not PPH.
you are augmentation of labor.
Induction and augmentation.
Yeah.
So
For induction,
it is incidence is more if we augment and induce with the misoprostol, and is it safe to use for augmentation? Both the things.
Yeah, the use of misoprostol, it has to be very used cautiously during labor. I generally, it's my protocol, I use misoprostol to augment the, I use gel, dinoprostol gel for the inductions and not misoprostol. But for augmentation, I use misoprostol 25 milligram only after the cervix is 5 centimeter dilated. Because if you use it when the cervix is not soft and effaced, it may cause tetanic contractions and when the cervix is not dilated. So we have to be very cautious. But I use after at two times I use misoprostol. One is after 5 centimeters and maybe if she doesn't progress well at 8-9 centimeters, but not at higher dose.
So injudicious use of misoprostol can
cause
really great harm, but judicial use might be beneficial also. But as she said,
precipitate labor can.
I read an article by Dr. Pai on use of misoprostol in induction of labor and augmentation of labor. So what they recommend is, as she said, 25 milligram of misoprostol per kilo. Now we have a small tablet of 200 milligram and then you break it 4 times. Okay. Some tablet may be 50 milligram, some tablet may be 20. And those centers who still have their 200 milligram tablet, what we recommended is dissolve that 200 milligram tablet in 200 ml of water. And if it will give 25 ml of water that water, it is better absorbed and more effective than even 25 milligram tablet. Than even giving 25 milligram tablet, because tablet has to get dissolved and then absorbed. So he recommends dissolve that 200 milligram tablet in 200 ml of water and give 25 ml of that water 4 to 6 hours as per your requirement. Well established, you can reduce the dose. 10, 12, anything you can, as many ml you want to. That's what Dr. Pai will recommend.
Only thing is precipitate labor due to misoprostol, due to strong contractions can cause traumatic labor.
Many studies with use of misoprostol are reported high chances of genital tract trauma and fetal distress.
yes, definitely.
So that was withdrawn for the inductions and also augmentation.
So this was a little bit digression from the topic of postpartum hemorrhage, but since we were at the misoprostol, I thought that this is a very practical point because a lot of people are actually using misoprostol, will say it or not. So probably the better way of using it is, as she said, if the cervix is very thin at 4 to 5 centimeters, otherwise not used.
So
Agree?
Yeah, we actually, when misoprostol was launched for approved for the drug as for induction in our hospital Cyan, when we were resident, that time the trials were done for the 25 microgram misoprostol from Cipla. So lot of variation is there from the which company misoprostol you are using. So if you use Cytolog or misoprost, they are very effective. Sometimes they are very potent. So the incidence of meconium stain lacer is very high with induction when you are using for induction of labor. Second is loss of variability. A lot of strong hypertonic contractions you will get, fetal distress. So lot of the incidence of C-section in your hospital is going to be high. So if you just go and introspect all your cases in your hospital, if you are doing lot of sections for meconium and if you use misoprost, you know what is the culprit. So if you want to increase your section rate, go for misoprost for induction. Second thing is that like madam had said, when to augment the labor. The protocol is always very clear that the membranes have to be ruptured. Never ever with membranes intact you should augment or you add oxytocin. So 5 centimeter, like madam said, you do 5 centimeter dilatation, do artificial rupture of membranes, check the Liker. Then you have the both oxytocin and prostaglandins are equally effective whenever the Bishop score is good. For whenever the Bishop score is poor, the gel works very well, misoprostol doesn't work, and like Chandrakant sir has already said, lateral uterine tears are very common with misoprostol, and we have seen lot of referral cases coming to Sion Hospital because like sir mentioned regarding that 25 and 200, very difficult to divide it and give it. And the case that my student presented regarding the rupture of uterus, that was the same point. People go overconfident on misoprostol. The staff use it very left, right, and center. Sometimes off record it is given to the patient, and these problems the consultants land in trouble. So the rupture uterus becomes very difficult to manage. Messy tears happen. Cervical tears and the lateral vaginal tears go up to the broad ligament goes, broad ligament hematomas. So actually what happens, these patients are referred to the tertiary care center. So the primary center don't know what is going to happen. Then झाला आणि patient वाचली तिकडे. But actually when you see here, you know what is happening and the periphery what is happening. So that is what happens.
Crisp and clear messages from panelists about misoprostol. For induction, be very cautious with misoprostol. If the dinoprostol is available, why worry our own head with misoprostol inductions? Use for augmentation, well, it can be good if used judiciously and never in a higher doses. So we have to be really very vigilant while using this drug.
For misoprostol, there is a good chart given by the FIGO protocol, which is called. I think they are modified in 2023. So the whole chart, first trimester to 40 weeks, how much dose, what frequency,
I think she has
everything
given
is
that
given. Yeah, so that chart is available. You just Google it, and we have actually pasted that chart in our labor room.
That's a good
so
idea.
we don't have to memorize what काय ते just बघायचं. So whenever somebody asks me for induction or want to augment, I just tell follow the FIGO chart, see the chart, how many weeks, and you put it according to that. So it becomes very easy. You don't have to remember because these charts keep on updating. So currently they have changed a bit, some plus and minuses they have done. So the newest chart 2023, you should put it in your labor room. So very important, it helps very handy. So especially even in second trimester pregnancies also, when we are doing for the MTPs, the frequency of misoprost, how it is to be used, how much to be used, it depends upon the weeks of gestation of the pregnancy. Not just it's a round figure for second trimester.
Yeah. And you want to say?
One more thing that we should be keeping the misoprostol, not let the staff do this, so that we have the proper judgment of effacement, dilatation, and all the things.
Now the panel discussion is like questions are too many. I will skip few questions because we want to listen to the cases also, and I don't want to be holding everybody up for their dinner for quite late. Yes. So there was one point I want to actually panelists to make clear to us, that whenever the successful management of any major or even for that matter minor postpartum hemorrhage is that starts with the correct assessment of the blood loss. Correct assessment of the actual blood loss, visibly it is not very good. We tend to underestimate when we go on the visual estimation of the blood loss. So are there any objective assessments where we can without even seeing? So suppose the patient delivers, sister tells me that she has delivered, I go and I see her in pool of blood. I don't know what has happened before, how much she has lost already. So visual assessment may not be good. Are there any objective assessments?
Visual assessments are always wrong. They grossly underestimate the blood loss because there is always a wishful thinking that our patient is not bleeding much. But there are different methods of assessing the blood loss, like you weigh the MOPS, okay, and then how much of they weigh after they have been soaked with the blood. Or there are now new sheets which have come where entire blood is getting collected in the pouch there, and then measure that what is the blood loss estimated. But that also can be admixed with the Liker, and the assessment can be overestimated But still, there is a way to manage. Once the patient has delivered, there is no question of liquor getting drained into that pouch, and then only the blood comes into that. So these are the methods, but I feel that they are for institutional research purposes. Okay. As a practitioner, we have to just estimate the blood loss. Visually, you have to overestimate the blood loss and take the proper measures before the patient goes into irreversible shock. You have to take the measures before patient enters into irreversible. That is the thing that we should remember.
Does this rule of 30 and the shock index help?
Many times I think the pulse rate is more important. When there is a tachycardia, we should feel that patient is bleeding more. The shock index is of pulse rate upon systolic blood pressures. As per pulse rate increases, the shock index goes to the 1. Normal shock index is between the 0.5 to 0.7. But 1 up to the 1 is dangerous. But we should not wait upon that. Whenever pulse is increases, according to Harrison, tachycardia is 10% rise in basic pulse rate. But when pulse rate from the 80, it becomes 100 or 110, that is the thing is that she is bleeding
Yes,
more.
sir. Precisely. Actually, we are very scared of, because we didn't like math, we became doctors. So when people tell us, look at the indices, look at the ratios and all, the half of our mind closes down that what it is, who is going to do all this. So this is a very simple index. I think, sorry, sir. No, sorry.
Probably Vijay wanted to say, it's not only the pulse rate of the patient, pulse rate
You
of the
are also.
obstetrician too is important in decision making.
Yeah.
So this shock index, if we see, suppose the pulse is say 80 and the BP is, systolic BP is 120. The value comes to 0.6. Okay. Now say pulse is 100 and BP, systolic BP is 100, the value is already 1, she is in mild shock. So we underestimate the amount of blood she has lost, and if we go by this, if the patient's pulse rate is 100 and BP is 100, we will be completely alert that she has already lost almost 1 liter of blood. Otherwise, she will not land in this mild shock. So I think this is how this will be helpful for us, but the only thing is that we should know the baseline pulse rate and the blood pressure. That is why it was important to. So you want to say something?
Yeah. So shock index is important, but the other thing that is important is if the patient was hypertensive before. So say her blood pressure was 170, 110 on admission, and now it is 140, 90 or 130, 90, or you will say it is normal. But that is not normal. For her blood pressure has dropped very much, so the drop is more than 30%. So whenever her systolic blood pressure is dropping down, so that is also you have to take into consideration. So for her 140, 90 may be shock.
Yes.
So it will depend upon what is her baseline blood pressure on admission. So that is very important. When you actually admit the patient, you take the blood pressure, pulse of the patient. That is the important part. So that's why in this shock index also it will not come. And especially in the rounds also, you should see every time you see the patient, just see the pulse. Anything going above 100, you have to be very careful and find out why the pulse is above 100. So it may be because of looking at the doctor also, the pulse may go high. But there may be other reasons why the pulse is going high. So you should find out what is the reason why the pulse is high of the patient. So very, very common this happens. So in the rounds you always, and everyone has that, you know the pulse. So you just feel the pulse for 10 seconds, 15 seconds and you know what is happening with the patient. So always that habit, whenever you see the patient, patient's हात पकडायला पाहिजे. That is very important.
There are few more questions, but I think we will skip through that right now and let's go for the cases. And if we get time, we will come back to that and discuss. Is that okay? Okay. So let's come to the first case, that is a third gravida with 38 weeks pregnancy with previous to LSCS, admitted for elective cesarean section. The intraoperative findings were, there were dense omental adhesions, the bladder was adherent, the entire uterus was adherent to the anterior abdomen ventro-fixation, and it was very difficult to create a window for the bladder also dissected down, with difficulty to baby to come out. That creation of that window was also difficult. And the most horrible thing was she landed into a tonic PPH. Now because we could not go to the parametrium, this systemic devascularization and all went out of window. So how will you proceed now? Sadhana ma'am, what would you like to do?
First of all, call for help. I think it is really very tough. First of all, you will try on our medical this, but I think we have to dissect upon the adhesions and try to go laterally to ligate the uterines. And
Anybody else?
go. We have.
I think systemic devasculation should not be out of question. It is, you go extra peritoneal and do it. What is the problem? Very easy to go extra peritoneally. The adhesions will be inside the abdomen. You go extra peritoneally, and you can go to the internal ligation. It should not be a problem at all. If you want to go, it's not out of the box. And adhesions and all that you have to dissect, and you have to, if the decision is of going for obstetric hysterectomy, I think we are going for peripartum hysterectomy in this case. You have to do sharp dissection and do the surgery. Maybe you will injure the bowel or bladder. That's okay. You call the surgeon; they will come and suture it. But patient will be saved. It doesn't matter. And another important thing: if you are too much scared of about the bladder, put methylene blue before you go ahead. So you ask your assistant somebody to put the methylene blue inside. Even if you open, you just suture it. There's nothing. Bladder will forgive you, and ureters don't come into the picture here.
I just wanted to say that this is all the result of Misgav Ladakh. Somehow Misgav Ladakh became popular amongst the young gynecologists because they wanted to finish the surgery fast, and they have landed all these patients in trouble. There have been a lot of literatures which are now against Misgav Ladakh technique. So see how intraocular lens came into practice, do you know? Because of the notorious resident of ophthalmology. Okay, they used to just remove the lens, and then the patients were given those soda water type glasses once upon a time after the cataract surgery. But one of the notorious students asked the teacher, "Sir, you have removed the lens but forgot to keep it back." And then the surgeon got the idea that, can I really have some lenses which I can put? And that's how the invention of intraocular lenses came up. Okay. So just to save the time, this Misgav Ladakh came up, okay, and caused so much of trouble. Still, if this is a situation, I think to minimize the bleeding, one can go for aortic compression, minimize the bleeding, low down, take your own time to dissect, and go ahead with the specific surgery.
Okay, so these are the actually cases.
We can take...
just a minute. These are the actual cases which have happened, and I am presenting it the way we did them. It may be right or wrong or whatever. I just want all of us to have a take-home message, what we can do and what we can't do, or can we do things differently. Now, what we did in this case was, we thought that let's try balloon from below. Does it help? Because it was atonic PPH which was not responding to the uterotonics, and there were a lot of adhesions. Probably surgeon would have been called for that. He will take 25 minutes to come. So we thought that we will use this Bakri balloon. So what we did was, we had an abdomen open over here, and we just gave a lithotomy position, and we under vision put the Bakri balloon, so there was no question of displacement or wrong placement or anything. Under vision we did that. And then we inflated the balloon with the normal saline, and because we had a complete picture of uterus in front of our eyes, we were seeing what happens, and from below whether the bleeding stops. From the below bleeding stopped, we were very happy. But what started happening was, the entire uterus started to fizzle out. म्हणजे ते काय म्हणतात, विरतं ना, कपडा विरतो. तसं the lower segment started to fizzle out on the top of that Bakri balloon. So then we immediately reduced the distension, and there were some button holes in the lower segment. We sutured them up. The hemostasis was achieved. But then, even with the distension of say 120 to 130 ml of fluid, the bleeding had stopped. So what we thought, that let's not do anything different right now, just pack the vagina below the balloon. We just stay put and see whether she bleeds more. If she bleeds more, let's stay in OT itself, and if she bleeds more, then we will go ahead with the rest of the things. But thankfully that bleeding stopped and patient recovered well.
Can we try some compression sutures at this time?
Yeah, we can. But the exteriorization of the uterus was difficult. It was so adherent.
Here the principle always remember what time the patient is induced and how much time in the surgery you are going. Because in keeping the balloon, then taking that panicker, packing the uterus, all these things we do, and the patient lands in a extended ICU state. So always rule of thumb, you should see how much golden hour you should not miss. So So if you're exceeding the time limit, these things, the balloon, Panikar thing, cannula, SR cannula, these are the, so these things happen in your labor room. So now you want to shift the patient, you have to call the anesthetist, you want to buy time. So there this balloon and cannulas work, uterine packing work. But on table if this happens, do not experiment too much, because you can experiment but you should keep a cut off time, 5 minutes, 10 minutes, not more than that, because by तुमचं सर्जरी व्हायला ऑलरेडी 40-45 मिनिट्स झालेले असतात आणि त्याच्यात देर इज अ ब्लड लॉस ऑफ द सिझेरियन सेक्शन विच इज 1 liter प्लस द पेशंट इज ब्लीडिंग अँड नाव वी आर एक्सपेरिमेंट विथ बलून कॅन्युलाज अँड ऑल दॅट अँड इन दॅट सेव्हिंग द युट्रस यू लूज द मदर. So this happens in so many cases, and these cases come to our institute for opinion. So then we are in big soup how to, what opinion to give. So this happens very common. So that's why I'm telling you, the internal iliac ligation surgery, these are life-saving surgeries, obstetric hysterectomy. You go ahead and do the surgery, patient will, most of the times will be survived, unless and until there is another problem. But you do all these experimental things, you waste your time in the time lag goes, and then the patient goes more than 30% of blood loss, you have lost the patient. 40% blood loss, they will go in DIC, they will go on multi-organ failure, 8th, 10th day, 11th day, they will die.
So
that is what happens.
I think the important thing is to have a dialogue with your anesthetist while the things are going on and an eye on the clock. If things are at hand, use them. If it is going to buy time for short period of time, like till the surgeon comes or till the help comes, and if it doesn't work, well, go ahead with the more
because that's
standard steps.
Yeah. So that's what happened, because lot of times I have seen patient is on table, PPH होतं, त्याला close करतात and they refer to major hospital, and that shifting takes 2 hours. By the time she comes here, she's already, you just have to do the formality surgery, put in ICU and send for postmortem.
So probably
but if you do the surgery in your house, so the best time to do surgery is then and there, and the best is the surgeon who's there. So you do your internal iliac ligation, obstetric hysterectomy, call your colleagues by the time and move ahead and do the surgery. That is the crux of the situation. So you have to do it then and there. Don't refer the suture and send the patient with PPH outside.
So
because especially for obstetrician I am saying, not for the other, but we are trained and we should be doing it.
So before sending the patient, probably shifting the patient of postpartum hemorrhage to a higher center, these are the primary things to do. Like if you can do the primary surgery at your own setup, if not skilled enough, better not to do it. If somebody else is not coming who is skilled, better shift. But while
I am saying that all are skilled, everybody should know it. It is already, everybody knows the surgery, everybody has done it. It is only in your mindset that you cannot do it. You just have to do it. It's a simple, you do so much, gynec hysterectomy, we are doing abdominal, left, right, center. What is the problem? No,
so Ghate
it is more easy. सगळं वरतीच असते.
Ghate madam, I think this is a good opportunity to start.
We are expert in doing cesarean section, but we are not expert
Madam, we all have
to
passed
go extraperitoneally and
No, I am not saying
ligate internal
extraperitoneal.
iliac.
I am not saying extraperitoneal is
So
also.
we have
Madam,
to take another workshop and
Deepak
training
Desai
for-
sir had come here and demonstrated in Rugnalaya only the surgery, and I have picked up from that surgeon. I am not saying I am not saying you should do. I am saying you can do open obstetric hysterectomy करायला extraperitoneal जायला लागत नाही. What is there in that? You have to do it. Surgeon
in
is
that case,
no, in this case, surgeon is available. You will injure the bladder, bowel, omentum, injure it, do the hysterectomy. Later on, you can suture aram se. What is the problem?
So, probably
that's what I am telling you. It is in our mindset. काहीतरी bowel injury झालं. You see how bowel surgeons operate. तिथे left, right, center, monopolar cautery वापरतात. आपण एवढं घाबरतो. लॅप्रोस्कोपी मध्ये आणि ते धडाधड क्वार्टरीने वापरतात सगळे सर्जन्स बघा म्हणजे
सर I think before going to internal iliac artery, we can always try for uterine artery ligation,
yes, that's
ovarian, and compression sutures are also
very
we can try.
Explained in our conference last Sunday.
If we are not confident enough to
devasculation of uterus करायचे आधी, that is according to protocol.
Though internal iliac artery ligation is the best, but before that we can do all
that
these
is very
things.
important, and I think
before obstetrical
wonderfully it
hysterectomy
was
also.
illustrated in the last conference by so many our guest speakers very nicely.
Like we all have oxytocin, methyl ergometrin, carbetocin, carbopros in our armamentarium. We all should have Bakri balloon in the armamentarium.
Yes, Bakri balloon has to be there in the OT. I am just saying that त्याच्यावर किती वेळ घालवायचं हे पण लक्षात ठेवा असं ते sometimes you your
No, insert the balloon and drink power, sir. That patient is coming.
Now let us come to the second case. A primary full-term pregnancy, spontaneous labor, all in ANC normal, vitals normal, patient delivered, active management done, baby cried well, placenta delivered well, but the uterus flabby with fresh gush of bleeding. Oxytocin started, bimanual massage given, but still the bleeding continued. Primary resuscitation was done, methergine, everything was given. Estimated blood loss now is 1000 ml. 35 minutes after the delivery of placenta. Then what should be the next course of action, Chandrakant sir?
I think if a uterus is contracting well, then there is a theory of living ligatures. If the vessels going through the myometrium, if myometrium contracts, it will be having a good hemostatic results. Williams says that if uterus is very good contracted, coagulation defect with the patients with the coagulation defects, patient doesn't bleed from the placenta side unless otherwise she has a trauma to the genital tract or the uterus. So the tone of the uterus is more important. If I keep a hand on the abdomen and the uterus is very hard, then I will think about the second, that is the trauma. And
no, but here the uterus is already flabby.
So it is atonic PPH. So I think that we should go for the uterotonics.
Yes, but uterotonics have failed.
If we should repeat the doses of uterotonic by manual compression, and then if doesn't works, then I will take it into the OT, explore vaginally for the vaginal lacerations and the cervical tears, and if that is not there, then I will go for the systemic devascularization.
Okay. Now, about what Pawar sir was saying, that the patient is shifted to OT now. She is bleeding, she is shifted to OT now. Now, do you want to try balloon or do you want to go directly open for devascularization?
So here actually atonic PPH uterus is contracted, not
flabby.
Not flabby, no. So it is atonic PPH. You have to shift to the OT, call for help. सगळ्यांना बोलवायचं, जेवढं गाव गोळा करायचं सगळ्यांना गोळा करायचं, डॉक्टर्स ना सगळ्यांना. So whatever help you need, you take. Always there can be PPH can be tonic mixed also. So tone, tissue, trauma, thrombin, all four factors you see, rule out.
Pure atonic PPH, patient is still vitally.
So medical line of
stable.
management is failing. Now you already crossed 35-40 minutes. You have to go for.
So would you use a balloon or would you open her up?
No, balloon has to be used in the labor room only. So by the time you shift, you put it in the labor room, you can put Paniker's cannula. What I am trying to tell you, keep a timeline. How much time you are going to experiment with balloon?
30 minutes.
How much time you are going to experiment with that Paniker cannula? So 10-15 minutes is fine. If it works very well, doesn't work, by the time your trolley is ready, everything, you prepare everything. In the meantime, you put the balloon and see. You will know the blood loss, you will know what is the plus blood pressure, your anesthetist will come by the time. Because to put the balloon, you don't need anesthetist.
No.
So you just put it inside, call the anesthetist, do the cross matching, everything, and do it.
Once you have shifted the patient to OT, everything should be for exploration.
Yes.
Okay.
Till anesthetist come, you can use balloon.
Yes.
Okay. So there is
what I mean to say, don't experiment, don't waste time. You stop the bleeding fast, whichever method it is.
That is very important message, that we should not lose a lot of time using balloon in the hope that she will stop bleeding. If we can do it, if we can go there and catch the vessel and catch the uterus and tie it off. So that is the important message. How much time we are going to lose on the conservative methods, that is also something we have to keep in mind. Now, if this patient is referred to our hospital from periphery, referred to a center from a periphery, no conservative management, only uterotonics have been given. Now there are no products at hand, they just panicked and shifted the patient. Would you, now her hemodynamically she is unstable, like pulse is 126, BP is 90/56, there is another like say half an hour, minimum 45 minutes for you to get the products, by that time you are just using crystalloids and all. So would you like to go for a more aggressive surgery, or still would you like to go for sutures? And
more aggressive.
You have
even
to say.
Even if she is a primary gravid, I would still proceed with subtotal hysterectomy.
Okay.
So it all depends upon how much blood loss she has had, and if she is hemodynamically unstable, she is already going in the stage class 3, class 4 shock. So once she crosses class 3, class 4 patient don't come out. So they will die. So class 3, you have to see that they don't cross class 3. So their OH has to be done. So first
this
go
is
in. That's
also
why
very-
I was telling that the primary surgeon, whoever has referred the patient, there only the patient has been missed. So that person, if that person is not able to manage at their center, so they don't have right to deliver also patient. If you don't have facilities of OT, don't want to do hysterectomy in your place, then you don't practice labor. Practice something else.
So
Go for
that is
IVF.
a very important message that sooner the better. And what is sooner, that they have defined what is sooner is before the patient starts becoming hemodynamically unstable. That is the time when we have to act. Always when cases of primary, आपल्याला असं वाटतं अरे रिलेटिव्स काय म्हणणार, आता म्हणणार प्रायमीचं असं कसं काय हिस्टेक्टमी केली. But if she loses life, we are going to land up in much more soup. So that is another take home, that act earlier than later. Now, what is sooner, what is, I think this is clear for us. Now, arranging PCVs and the products, I think we already discussed that. How many of us are doing anyway? How many of us are arranging for all cases? Yes, so a few hands have gone up. I request all of us that please more hands should rise up for this, because this is very important. There is a intensive care protocols, the newer concepts that are coming, they are against using the crystalloids for for the hemodynamic stabilization, because more than 2.5 liters of crystalloids when used, patient goes into dilutional coagulopathy. That is why they are saying that act before that, start transfusing the products before you use more than 2 liters of products. If there is a massive PPH at our hand and we have to transfuse fluids rapidly, there is no way that the product is going to be available within 30 minutes, 45 minutes if it is not arranged before.
It takes 45 minutes for the cross matching for any
So-
blood. You can't get cross match in 5 minutes.
So that is just maintenance of blood pressure is not important anymore according to newer concepts. It is the coagulation status of the patient being maintained that is very important while resuscitating the patient, and that is why we have to be sure that we are doing a sorry.
Yes, sir.
Medicine, the most controversial subject is obstetric practice, and we have heard enough about arranging packed cells for every patient. So you mentioned rightly there is a controversy, there is going to be a controversy. My question is, so you initially mentioned two categories, high risk for PPH and low risk for PPH. So what is the incidence of PPH? Now my question to panelists is, what is the incidence of PPH in high risk cases, high risk group, and what is the incidence in low risk group? And one more question, because see residents, everyone is practicing in Solapur, we need to think about the burden on the blood bank also. So arranging so much of blood for every patient who delivers, because lakhs and lakhs of people are delivering, and not everyone will practice in Solapur. Suppose a person in Sangola or Mangalveda or some other place where arranging blood may not be that easy.
Sir,
So,
I'll take this question. See, there is something called as good clinical practice. So if you don't have a blood bank in your city, obviously it will be accepted in court that whatever was available in your city you have done it. But in Solapur you cannot do because your blood bank is available.
See,
That's what I'm trying to do. So there are certain good clinical practice guidelines. These are not that you should cross match 2 blood, 1 blood. Like in medical college, I cannot also we have 30 deliveries per day. I cannot cross match 30. My blood bank वाला तो मारायला येईल मला. What they do, we send the blood. The pathologist will keep it there. He will not cross match. Just keep it with us. And whenever the blood is required, that time he cross matches and gives it. This is the मधला मार्ग. क्रॉस मॅचिंग सॅम्पल जातं ते पॅथॉलॉजिस्ट करत नाही, कारण जसं तुम्ही म्हटलं इट इज इम्पॉसिबल फॉर टू क्रॉस मॅच 30 ब्लड, बट फॉर प्रायव्हेट प्रॅक्टिशनर्स इट इज ब्लड बँक्स आर अवेलेबल आणि दे आर गिविंग सर्विस लाईक झोमॅटो नाव, घरी येऊन ब्लड देतात. So there's no problem.
Before answering Ajit Kulkarni's question, what WHO says that between crystalloids and colloids, crystalloids is the first treatment that should be set in, because colloids cannot be used because they have their own problems of allergic reactions and interfering with coagulation. That's one.
Even cross-matching it.
Even cross-matching, yeah, that's one. And second is, sir, your question of how many, what will be the load on the blood bank? No, the cross-matching does not mean that the blood is issued. Okay, so the same blood can be cross-matched for 10 different patients. So it's only the cross-matching which is just kept ready in the blood bank. You will ask the patients to, or the blood bank to supply that bottle if required. Otherwise, it can be used for the patient who needs it. So it is, in fact, for the private blood banks to survive, they need more and more samples to come for just cross-matching and not use the blood products.
We immediately inform the blood bank that now patient is okay, they can issue for the other patients. It's only 48 hours it is kept, then it is used for other patients. So multiple times it.
Now, I'll finish it in 5 minutes, I promise. Suppose a case of, we open the abdomen for previous LSCS or 2 LSCS case, and we see that there are, placenta was anterior, but now it was up only, but now we see the very angry vessels looking at you, probably crossing to the bladder, and we know that we have landed up with acrita. Now, I am at my private nursing home, opened up a patient for LSCS, probably 1 or 2, if the update sir is there, 2 cross matches. So, what should I do now?
See, when you find that you are expecting that once you take the incision there will be bleeding. Now, what is the indication of your section? That it depends upon that. If she is bleeding heavily before on tape, like she is coming bleeding TV.
Accidental.
Now accidental आता होत नहीं because we all do ultrasound beforehand. So that is there. But if you ultrasound, it is diagnosed before. But now if you hypothetically,
Power sir, what she is trying to say, ultrasound told that the placenta is anterior, little low lying, and you find that it is percita increta, something like that.
So now you have already jumped into the water, you have to swim.
Yeah.
So now only thing is what to do first. So you want to prevent the bleeding. So what actually we had presented one case before also, you can actually, what we do is that we first dissect both the internal iliacs. We put the suture over there around the internal iliac. So don't you deliver the baby first. You put the sutures there, don't tie it. Just take आपली लेस सारखी knot मारून ठेवायची. You then take the incision above. So wherever is your placenta, you take the incision above. Whether you're taking, mostly we take the transverse incision, deliver the baby. Now don't try to deliver the placenta. Babyला देऊन टाकायचं, ते दोन्ही साईडचे internal iliac बांधून टाकायचे.
So, but all this should I do at my private nursing home?
Yes, now आता open केल्यावर कुठं असंच पाठवणार का परत?
See, the recommendations are abandon the procedure. This is SOG saying, not me.
Abandon the procedure is because in America there is a different status of conditions. In India it is not.
Madam, acrita and percrita should be in the multi-speciality hospitals.
I agree.
With all things, urologist, physicians should be ready.
No, I think
if I have not taken incisions on the uterus now, I will close it. I will shift to some multi-speciality hospital, and I will do all these things to be there.
What would the other panelists do? All of sir though is a master, he will tackle anything.
I will agree with Chandrakant.
No, that is what I'm telling. Heroics try nahi karayche, but like if your indication now. No, that's why I asked her what is her indication.
It is heroic.
No, what is her indication for surgery?
Now I realize both of them belong to different units.
No, we have worked in same unit.
I agree with Pawar sir. As we have opened, you may lose the patient until you shift her. So you call for help.
That's
if you
why I
can
asked
do
you what is
cesarean.
the indication for surgery.
It's a
Suppose
elective
if it's a
surgery.
fetal distress. आता fetal distress ला close करून पाठवल्यावर कसं करणार?
Elective surgery. Elective section.
That is what I'm telling. If it is an elective section, it is impossible that you don't know where the placenta. Ultrasound केलेलंच असते.
No, where the placenta everybody knows.
What you are saying in SOG guideline, they have already diagnosed it. असं होत नाही
Per
अमेरिकेमध्ये
increta
डायग्नोस.
sometimes are missed on ultrasound. It is wishful that
No, see,
it should not be missed, but practically
लो लाइंग प्लासेंटा आहे,
no,
प्रिव्हियस
not
सर्जरी
low-lying.
आहे.
Low-lying placentas are looked at very carefully. What sir said is very important. Low-lying placenta, we all look at them very carefully. Central placenta, low-lying placenta, we are super careful. But previous surgeries with anterior placenta with slight extension on the lower segment is the worst thing. There we can miss
No,
things.
that's what I'm telling you. तिथे we have the cervicoischemic stitches there. So all surgeries are available. What you have to do is you have to do, that's why indication is important. The fetal distress असेल you have to do. Otherwise you can close and send. There's nothing wrong in that. Many times we do abandon hysterectomies also. No, and if you find it difficult, you close and shift.
So
There's nothing
if
wrong in
suppose
that.
we close such patient and we shift to tertiary center, when to shift? Because patient is already under spinal. Now
Immediately shift.
She cannot like.
Not an emergency, so let her come out of spine and then you can shift her. No problem.
By that time, probably alert the institute also. So it depends upon the state of readiness of your own place, depending upon your own expertise, how much help you are going to get. As sir said, somebody practicing in Sangola, not with having blood bank backup also, and probably not a second senior skilled surgeon also to help, how much risk that person is going to take. And if the patient is not actively bleeding, there is no urgent indication, are we justified in opening her up and going ahead? So all these are the food for thought. I think with that note,
One point I would like to add, there is a vascular clamp that is called Satinsky's clamp. So this there is a aortic clamp and arterial clamp. So this clamp everyone should have in their cesarean section trolley. Drum it is a Satinsky's clamp, vascular clamp. All vascular surgeons use it very regularly. So that clamp you always keep in your, one is mixture has to be there, 2 mixtures in your, आणि OHC trolley जे आहे म्हणजे all your coccus clamp, Hinnis clamp, whichever clamp you want, all those clamps have to be in your cesarean drum. You can't, आता OH लागणार आहे, मी autoclaveला drum लावणार आहे, बोलवणार आहे, ते संपलं मग. That has to be in your cesarean drum.
So again very important.
So vascular clamp you should keep. त्याच्यामध्ये एक आता we have an aortic clamp. So आता जे आपण पहिले aortic compression करतो. So this actually you can learn from the cardiovascular surgeon. They have that Satinsky's clamp. You just clamp the aorta for 2 minutes. Nothing happens. So your field of vision becomes clear. You know where the bleeder is. You just release the clamp again. So there are so many things you can just go on doing this. Very very.
If you have the pictures of these,
I'll
share it on the group so that it will be for our benefit.
This actually every gynecologist should have it. That
so the placenta previas, low-lying placentas, and all the difficult placentas, the things to go in the drum before hand. These are the apart from the cesarean section instruments.
So Bakul, before we disperse for dinner, Vijay Power promises to send the picture and the supplier of that aortic clamp. Thank you.
I'll send.
Oh, so I thank our panelists for giving us such wonderful inputs and very practical, important. And
even what you can do, त्याच्यामध्ये if you are not comfortable, there's like Madam said, there's complication. Our setup is not compatible with managing such patients. You can just clamp the vessels. Internal clamp करा येत नाही ligate करता, just clamp the vessel with that clamp, close the abdomen, shift the patient to tertiary, there you remove it. Or there is another like the 3 P's, pack, pressure, pray. So everything you pack the pelvis, that's the last resort. You have to just pack the pelvis with the whatever you have linen. So directly pack, close it, and then you shift the patient. That is also there.
So damage control surgery where actually open and closed we can and.
So whenever you are shifting, that always helps.
Yes.
That.
Thank you everybody. Thank you so much.
I request our President Ghate Madam to felicitate Dr. Bakul Jagirdar Madam. I request President Dr. Ghate Madam to felicitate Dr. Dabde Sir. Dr. Sadhna Deshmukh Madam. Dr. Vijay Pawar, sir. Dr. Chandrakant, sir.
It is my immense pleasure to give the votes of thanks. Thanks to Dr. Rushali, Dr. Vijay Pawar sir, Dr. Avantika, Dr. Dabde sir, all the panelists and the Vasu Organic. Is there Ashwini Koli and Ashwini Jadhav and all delegates.